All Stopped Up, Lymphoma Presenting as Acute Renal Failure and Constipation by Sharul Saxena and Matthew Darrow. Diffuse large B-cell lymphoma is the most common type of non-Hodgkin's lymphoma, accounting for 25% of non-Hodgkin lymphoma cases. It originates from B cells, and while the pathogenesis is not understood, the most accepted explanation is it arises from gene mutations involving BCL6 and BCL2. The initial presentation of DLBCL is often extranodal, manifesting as a mass. This case demonstrates how it can also present as renal failure. Patient was a 71-year-old male with history of prostate cancer, status post-prostatectomy, and hypertension, who was admitted complaining of constipation and anuria for several days. Upon presentation in the ED, patient's labs were calcium level of 15, creatinine of 7, and BUN of 86, with baseline renal function unknown. CT showed enlarged lymph nodes in the abdomen, one which was compressing the bladder with resultant severe bilateral hydronephrosis. Immediate nephrostomy tube placement was performed. Following the procedure, nephrostomy tube output was 7 liters. A post-obstructive diuresis was present for several days, which eventually resolved, as did the AKI with final creatinine of 1.6. Full hypercalcemia workup showed a PTH level of 11.4, vitamin D25 hydroxy level of 15, and PTH-RP of 19. Hypercalcemia was initially managed with calcitonin and hydration. After improvement in renal function, zoledronic acid was given, which resolved the hypercalcemia entirely. Preliminary biopsy revealed large B-cell lymphoma. Staging CT showed lymphadenopathy throughout the chest. He was initiated on R-CHOP. After his first dose of chemotherapy, he was discharged home with nephrostomy tubes in place and will follow up with oncology, urology, and nephrology. This is a patient who came in with anuria and was determined to have DLBCL causing obstruction, resulting in renal compromise. The objective of this case is to show how the first presentation of lymphoma can be dysfunction of an entirely different organ. While it was presumed that the patient's hypercalcemia might be from malignancy, PTH-RP was low, thus his hypercalcemia could be from kidney failure. Elevated calcium could be from osteolytic metastasis of the primary cancer. However, this is more common in solid tumors, such as breast cancer. Interestingly, recent studies have suggested that hypercalcemia is common in patients who are newly diagnosed with DLBCL, with prevalence ranging between 1.3 to 7.4%. While the exact mechanism is yet to be unveiled, it is thought that in such patients, hypercalcemia is caused by elevated calcitriol, or 1,20-vitamin D hydroxy. This case demonstrates how the first sign of advanced lymphoma could be severe electrolyte imbalance from renal failure.